Kevin represents, my, sister. Well, not
What? I know
Jillian?
I know my hair looks good, but not that good. Come on. Welcome to Rise Above. I'm Kevin Lanning, your host. In today's episode, we sit down with Rachel. Rachel is a primary therapist at a substance abuse mental health facility. Rachel, welcome to Rise Above.
Thank you. Happy to be here.
And we also have a guest co-host,
Ooh.
Allie.
I love the sounds of that. Hello, everyone.
Welcome,
back
Allie,
on.
as well.
Thank you.
Soft welcome to Allie. Hard welcome to Rachel.
Yes. Who is also my roommate / one of my best friends. Just got to put that out there. Amazing
that.
human being.
You you pulled this all together for us. So thank
She
you,
did.
Allie.
She's a gem.
So Rachel, tell us, how did you get into your line of work in mental health?
So it's actually a funny story, and I'm not sure if I think Allie knows most of the story, but so when I was in college, my major actually wasn't psychology. So it was originally broadcast journalism, which is ironic that I'm doing this now because when I started taking like my major classes for broadcast journalism, I realized really quick that this was not my forte. And I was like, let's not do that because I was like, I have a lot of like stage anxiety, performance anxiety. That's just like me. So I was like, you know what, let me pivot a little bit. And my minor was always psychology. And I always found it really fascinating. I always really gravitated towards it, especially from like my background and my own history with my traumas and what I've gone through in my life. And I've always just really felt the need to help other people. And I was always just I've noticed along my life, I was always really the one that people always asked for support, for questions, for like guidance, that kind of stuff. And not that I knew anything back then, and that is as does any friend, but I think that was kind of like my gravitational pull towards it. And then after I graduated and I changed my major to psychology, I knew that I wanted to be a therapist. So I went straight to grad school right after undergrad. And ever since then, I've been working in the field. So,
And here we are.
And here we are.
Were you the mom of the friend group growing up?
I was like the crazy mom. So I was like the one that like I got all the ducklings together, but also we were gonna, have fun as well.
Do some crazy shit.
Yeah. So I've had my crazy times, but
Everyone loves the crazy mom. Everyone.
What's not to love,
Yeah.
Sounds about right.
Yeah.
So you graduate from grad school and you decide to pursue a career
Yes.
in substance abuse within a mental health
Yes.
facility.
Yes.
So tell us a little more about that and what your day-to-day looks like.
So, like you said, correct. I work at a dual diagnosis facility. So we have clients there that are there strictly for mental health, strictly for substance use, and comorbidities with both. So I can have a range of, I want to say about 11 to 15 clients, which is a lot. And you kind of take care of all of their needs. And I work at a PHP level of care. And there's multiple different cares, levels of care, and I can go into that a little bit later. But PHP stands for partial hospitalization. And so it's kind of basically like an outpatient. It looks a little outpatient, but I think of it like a work day. That's kind of what it looks like, and how often the clients are coming to services for us, seeing me for therapy. And at a treatment center, we offer a lot of other kind of services, not just individual therapy, but we have group therapy. At my specific rehab that I work at, we do neurotherapy, which does brain mapping, which is really cool, and it can sense like the different wavelengths of your brain to see what areas are overstimulated, understimulated, or within the normal range. And then we also do EMDR and ART therapy, which is the trauma therapies that I'm both specialize in as well.
So I've been to many mental health facilities, more than I'd like to admit. And my thing was drug addiction. And drug addiction was a symptom. The root of the problem was some kind of mental health issue that I had going on deep down. What is the most common mental health issue that you come across in your facility?
That's a great question. I think, from my personal experience with it and from working in the field, I think it's unresolved childhood trauma. And I can go into a little bit of what, trauma looks like, because a lot of times I think there's a lot of stereotypes and stigmas of what trauma is. I think sometimes people think it's supposed to be like, oh, I had to be in this serious car accident or,
Right.
serious sexual assault and yes, of course, those are definitely traumas, and those are what we call big T's. And then we have little t's, which is just basically any kind of trauma in a nutshell is anything that has disturbed or made a negative impact on your life. So that can be multitude of things, and often it stems from any kind of childhood derivative. So that's kind of what I think is, to answer your question, what's the unresolved mental health issue.
Can you give us actual examples
Sure.
that you've come across for that would pertain to the big T and the little t?
Yeah. So overall, I think big T's and little T's actually go together very often. I think sometimes when people don't really know either how to cope or have just mimicked a lot of systemic issues at their family, like generational trauma, that happens a lot where they just kind of do the same thing and kind of they're in that fight or flight or freeze mode, and they kind of just adapt or survive. And that sometimes is with negative coping skills like substance use or sex addiction or with, depressive episodes or things like that. So that's just what kind of continues on until you get to kind of the root of the trauma. And that what I do with EMDR and ART is you kind of have to break it down of like what happened in your life. Anything monumental or non-monumental that you think. It could be like bullying from a best friend from when you were 6 years old to, someone maybe, called you a name that maybe you identify, and that can be tracked down to a negative core belief system that you believe about yourself that ties into I'm not good enough or I'm not worthy. And a lot of times people use like substances or external validation or codependency or those kinds of things to kind of like justify or make themselves feel better to deal with it.
Okay. And so when someone comes in with, let's say, and I could imagine big T problems, big trauma problems, small T problems, how is that approached in the very beginning when you have a new patient that is coming in with a multitude of different levels of trauma?
So we have a couple different, and you might know from your time back there, but there was.
Are you saying I have trauma?
Perhaps.
Of course I do.
We all do. It's okay.
Yeah.
But so when they first come in, and also let me preface that it depends on like the client's willingness and capability. Like if they don't want to do something, I'm not going to force them to do it. And also no one can at the end of the day, like I'm not a magician or like Houdini or things like that, but I will challenge the client, but I won't necessarily make them feel or do something that they're not comfortable with. But in the beginning, there's a lot of assessments, clinical assessments. One of those is a biopsychosocial. We just call them bios in, layman's terms, but that asks a lot of detailed questions about family, about your background, about any kind of environmental issues, and a lot of like trauma. So people will just be honest. And when if hopefully, like I said, if they are honest and want to work on things, they will outwardly tell you that. There's also ways, we call it's one of the therapeutic techniques. It's called motivational interviewing. You kind of ask the certain questions to kind of see like, what did your family look like? Because sometimes people don't really know what trauma is. I've had clients, and I know other therapists that I work with have clients. They'll be like, oh, I never had trauma. And then they'll be like, well, yeah, my mom tried to kill my dad. And you're like, that's trauma, sweetie. But like people don't really understand that because they're just used to being it like, and there's probably a stigma tied with that of like, well, I can't say that that's a trauma because that makes me weak or that, whatever narrative they have in their head. But yeah, there's a lot of clinical assessments in the beginning. And when I meet a client in the very beginning, after all the assessments, I kind of ask them what they're looking for in treatment. And sometimes people already kind of know, like, and if they don't know, I just educate them on like, is this something that you would, when I kind of do the motivational interviewing, what's kind of happened in your life? What did your family look like? What did that dynamic look like? Because they might be able to answer those questions, and that might help me get a better understanding of if they had trauma versus me asking, so what's your trauma? You know what I mean? Like people aren't really going to ask that or answer that. So I kind of weave my way around that. And sometimes people are just very forthcoming about it. And then that, if they're very upfront about it, that's when I give them kind of like the prep work. We have like a bunch of assessments for the EMDR and the ART that's specific for trauma at my facility.
So you did mention EMDR and ART
Yes.
multiple times. Can you unpack that
Yes.
for the audience?
So EMDR, I'll start with that one. So EMDR stands for eye movement desensitization and reprocessing therapy. It's just a fancy word for we kind of reprogram and we kind of desensitize you to your trauma. So you won't like forget or like pretend something didn't happen, but you're going to change like the level of distress. So, and disturbance you have to the event. So let's say, for example, it's some kind of, like, let's say it was a car accident, like a really, really terrible car accident, right? And like we have you rank the level of disturbance, right? When you think of it today, because sometimes people can think of something that happened 10 years ago and it's still very like disturbing in their body or to their or in their mind. So I have them rank it in like a trauma timeline, and I have them rank like those different kinds of traumas that they have. And you're supposed to kind of go with EMDR based on your first childhood memory. But if something's a higher distress level, like higher disturbance level that happened more recently, you can still do that first. And kind of sometimes when you desensitize that first, the other ones can follow in suit. But so basically, you take any kind of external stimulus. So with EMDR, I use like, they kind of look like little paddles. And one has to be in each hand. You can also use eye movements, and eye movements, you kind of go back and forth, and people have to follow your eyes. So it has to be some kind of bilateral stimulation, and it's two things processing at once. So the bilateral stimulation mimics REM sleep, which is what a big part of your sleep when, like it's your REM cycle. I'm sure people have heard of that. That's a big part of like how you process and how you like interpret what went on throughout your day. So when we mimic that REM sleep, and then on top of that, I'm asking you some kind of questions. I'm kind of being like, okay, bring up that first initial memory. And then what other negative core belief that they tie themselves to that car accident. So maybe the car accident, happened when they were younger, and then they felt like I couldn't save my family. So that means that like I'm not good enough, or that means that I'm bad, or that means that, I'll never be capable of love, whatever that means. They could have it just depends on the person. And then we bring up that. And a lot of EMDR is actually interesting because it's not talk therapy. So I'm not really talking to you. I'm like asking you a question. I do the bilateral stimulation to mimic the REM sleep, and they kind of figure out their own, like, change their internal system. So what happens if I say, Kevin, like bring up that car accident for you, I'm going to give you the little paddles, and they're not shock paddles or anything like that. They kind of mimic
They just vibrate. Right?
Yeah, they're vibrations. Yeah, I showed it to you. They're vibrations. They're like not painful or anything like that. And then you put them in your hands, and I tell you, bring up the memory, bring up that negative core belief, and you see where the mind takes you. Because sometimes, like, even when you're daydreaming, like, you'll have a random thought of like, oh, like, I remember when I was like surfing when I was a kid, and you were like not even near the water, and like that randomly pops in your head or something like that. So your brain can open what we call channels and float back to different parts in your life. So we just go with that, and that's literally what I tell them. I say, go with that, and we keep going the paddles, and then their narrative, I'm like, okay, what did you notice? What came up? And it takes longer with EMDR, and like I said, I'll go into ART, but EMDR takes a lot longer because I'm not really being like, okay, now do this, now do this. I'm having them change their own narrative. And sometimes if they get stuck or things like that, I can speed up the movements, or I can, take them back to their original memory if it goes too off track or things like that, and help guide them, or do like what we call like interweaves, which is like basically guiding them through if they were getting stuck and like the car accident was my fault, the car accident was my fault. And I can be like, were you driving the car? Be like, you know what I mean? You can like, and like, no, like how could something that's a motor vehicle that's out of your control be your fault? You can like do interweaves in there, but for the majority, you're not really speaking. You're kind of guiding them through it and seeing what channels unlock in their brain. And this is why I said the earlier the better, because sometimes that car accident that, let's say, happened at like 16, that could bring up something that happened at 6. So like that, it just all ties together. But it's never like a bad thing to start like, later. You can still start later. It just depends what the level of disturbance is. But it usually ties back to other stuff. So
is this the cognitive aspect of trauma? Because you have, correct me if I'm wrong, you have cognitive and you have the physical aspect of trauma. This is penetrating the cognitive and rewiring your brain, correct?
Yes. So, and since you're like kind of guiding them and they're kind of changing it for themselves, they kind of, and you kind of, in the beginning with the prep work and everything, you ask them what they want to change it to. So if their negative cognition was, I am bad, you can change it to, I'm okay now, or whatever. Usually they kind of have to mimic each other a bit, but then they come up with that narrative when all the different channels have been unlocked and you kind of guide them back. And then it's just cool how your brain already knows what to do. You just let it do it. Yeah. It's like, people think it's a lot more like, oh, but what are you doing? I'm like, yes, I am doing it. Yes, I am guiding you. Yes, it is stressful on my end too. But it's also very much so like, it's a beautiful process because you're the one changing your own narrative in your mind, which is more powerful than having like an external source say like, oh, you're amazing, you're fabulous. But if you don't believe that about yourself, you know what I mean? That's why external validation doesn't really work. So
it seems like really that's what therapy comes down to is like, correct me if I'm wrong, but like as a therapist, you're not supposed to ever tell someone what to do, but kind of just like question them to kind of figure it out for themselves, right?
Yeah. And like I'll give them clinical suggestions and, you know, I'm still a hard ass. Like I'm sweet. Like I always tell them I'm your biggest fan. I am. Like I believe in my clients like wholeheartedly, but I'm also going to check you, you know, in like a nice way. I'm going to be like, hey, but like, what are you doing? Because you already know what's going on. And if it's like, if you want to repeat that same cycle, then that's on you. You can do that. But where's that going to lead you, you know? Yeah. So I will give clinical suggestions and recommendations, but I won't ever be like, do this, do that. Like, no.
Right.
So that hard ass side of you is that, for me, speaking from an addict's perspective, I need that. And to elaborate and, you know, on what Allie asked, I need to do it for myself. In order, you talked about the willingness in the very beginning and the people come in, even taking that first step of actually going to a treatment facility, because these are all adults. They can do whatever they want. They can leave whenever they want. They don't have to be there.
Yeah, no, all volunteer.
So I have had situations rather, where I took that first step. And then I was like, whoa, what I get myself into. And then I shell up. And then I don't want to talk about my traumas. But I also need that little hard-ass voice every once in a while. And that's my sponsor today to, you know, stay on me. But I will, at the end of the day, when I am pushed a little bit, will connect those dots and do it for myself. And the only way, everyone in my life always wanted me to get sober, but it was until I was ready. But even though I am ready, and I'm saying this for the audience, if you take that for even listening to this podcast, if you're looking for, you know, education on trauma, because maybe you're experiencing something, or someone in your family or a friend, you're taking that first step to get help, which is a huge deal.
Oh, it's everything.
So that was EMDR.
Yes.
Now, do you find a lot of patients EMDR works for people who have had trauma from 1 to 8 years old? Because I feel like they say that is a very crucial time period in your life. Or do you see a lot of the trauma from 9 to however old they are?
Good question. So EMDR, actually, when I was being trained in it, they actually said like that ages 1 to 3 are like the most pivotal, which I thought was very interesting because I was like, I don't really remember that.
Yeah.
But you'd be surprised what someone's like earliest memory is.
Yeah.
And
Your
even if
brain
it's
is
not
a sponge when you're that little.
It is. And you remember a lot more than people think. And kids are very, very literal, right? Like it's kind of like almost like when like a dog, like, you know, you have a dog and like you leave and then they don't know you're not coming back. Like they're like, dogs are like literal like that. That's kind of how it is for like early children. They don't really understand those kinds of concepts yet. But that's why they said early childhood. But I do think that like the pivotal years are in general could be 1 to 8, could be younger than that. But I find that if someone has a traumatic, at least from what I've worked with, if they have a very traumatic like early upbringing years, they will definitely, or not, I shouldn't say definitely, but they will usually have a lot of other traumas or things that happen either situationally or environmentally or just with their own behaviors and how they experience life. Like other things will go on, and that kind of like you can work with both. You know what I mean? So it doesn't have to be necessarily like EMDR is only for the 1 to 8, but it does usually what happens during that timeline will somehow affect, especially if it's for substance use. I'm sure like that didn't pan out too well, like later on in life. So then that's, you can tie them both together.
Okay.
Yeah.
That makes a lot of sense. So what is ART?
So ART is faster. ART is a lot faster, and it's not cognitive. It's kind of like what you said, like body versus mind. ART is all like body sensations. So, and so is EMDR. We'll still check in with you. I still tell them to breathe and all of that and check in with their body and stuff like that. But you kind of go back and forth. But ART stands for Accelerated Resolution Therapy. And I'm really kind of guiding them through stuff. So I help them. There's kind of like a whole format to it. I first have them like gauge whatever level disturbance and what emotions come up with that. I have them like scan their body, see what's like where the disturbance is in their body, and I have them process it out. And process it out is with the eye movement. So it's basically like I have them follow my hand back and forth. Like you're not supposed to move your head, you're just moving your eyes back and forth. And again, it mimics that REM sleep. So they're similar in a lot of ways, but they're different where I'm guiding you through a whole narrative. So we pick the whatever disturbing event it is. I have them go through the whole thing in their head. Again, there's not a lot of like, we debrief like in the middle when I ask you questions, and we'll debrief at the end, but not really like in the middle. Like you don't talk during like the eye movements or for EMDR during the sensations. So when I will talk to them, and be like, okay, I just guide them a lot more in ART. So I first have them go through the whole entire thing of whatever the disturbance. So I'm just saying car accident for this purpose. I have them go through the beginning, middle, and end with the eye movements. If they're still kind of like going through the whole event in their head, I have them keep going, and I keep moving my arm until they're completely done. And then I guide them through like what we call director scene. And then this is kind of where like they change. I'm like, and they're not losing like the facts of what happened. They're just changing the distressing images and the distressing feelings that they have associated to it.
Yeah.
So I've also, when we had to get trained in both EMDR and ART, we all had to do it too. So I like know it also works because I had to do it for my own stuff too, which was really cool. But yeah, with ART, it's faster. Like you can literally do a whole thing in like 1 hour, which I think is people are like, oh, the trauma's going to take so long. And like, yes, like obviously there's deeper, it's still going to come up and things like that. And there's more to process out, but like it will make you feel a lot better ART initially. So we usually, for clients, how I decipher what I'm going to do is also like time. Like sometimes I work at a 30 to 45 day rehab. So like sometimes I will do ART more because it's just quicker, but it's less thorough because it's not doing with the cognitive interweaves and the, the cognitive negative distortion part of it. You know what I mean? So it's only really mainly with like you're directing them through the new, okay, what do you want to put in the new scene? What associations come there? Is there any snapshots from the past scene that's coming up? Okay, let's go through them and erase them. Like you literally go through it step by step with them, but I'm guiding them through it versus an EMDR, they're kind of like doing it themselves. I'm not really guiding them through a whole director. I'm not guiding them through a whole script. Like they're kind of just changing their own. Does that make sense?
Makes a lot of sense.
Okay. So would you say that ART is a little bit more physical? Like you were talking about your physical body because I've seen from years of teaching yoga, I've just seen so many people have, myself included probably, have trauma like stored in their body, especially their hips. So a lot of times like people will get emotional when they, start to open up those energy channels, if you will.
Yeah.
Do you think that, I don't know if like ART is a little bit more physical compared to EMDR?
They're both like, I think ART checks in a little bit more with the body, but you can definitely have a lot of physical like reactions to EMDR too. I've seen people like break down. I've seen like, have like, I need to just stop and like just de-escalate. And like, we put a lot of protective factors in there too. Like I make them have like a container, and a container is like, they pick up whatever kind of container. It could be like a bento box, or it could be like a, I had one client have like a bomb like shelter that was like under, underground or whatever. And it's just a place where they feel like if there's any lingering feelings after that session's over for time purposes or whatever, they can put all the other stuff in it and feel safe. And then they have them come with a safe place. And it's either real or imaginary. They can have whatever they want. And it's just a safe place where they feel that they can go to, and they have to be by themselves because you don't really want anybody else in it, because then that image or safe place can be distorted. Not even any pets, because, if pets die, like then that kind of like changes. I know it's sad, but like that, they're like, oh, I want to put my dog with me. I'm like, we love the dog, but we can't have the dog there because like it will change like the safe place.
Yeah.
So you can put like happy memories and things like that, or like the beach where you used to like to go with your dog, but you can't.
Right.
That
makes sense.
But Yeah, so I think there is like sensory stuff in both, and there definitely is, and I've seen them have like visceral reactions to it, like bodily reactions to both. But ART, I think you check in with your body sensations more because trauma is really held in the body, and a lot of times when people operate from the flight or fight mode, they don't really take time to kind of touch in with their body, and that's why mindfulness and breathing and like yoga and all that stuff. We also offer a lot of that stuff at my treatment center because it's so important to kind of like regulate your body because your nervous system is going all the fuck over the place because you're trying, like you said, like sometimes when people give initial buy-in, like, oh, I'm ready for this, and they realize, oh, fuck, like this is what's coming up right now. Then they're like, oh, let's not do any of that. Yeah. So it's trying to get you back into your body when people don't really want to be because they're operating from that, fight, flight for so long. Yeah. So that's why people run or they fight or they do all those kinds of stuff. And it's kind of just like regrounding them back in like, okay, this is what we're here for. And that's some of like the tough love / love part. Yeah.
The mind-body connection is so real.
Oh, yeah. For sure. And a lot of things are like, I've seen it too. We've had like a couple clients that like, things are like very like psychosomatic, like they think something's there. And like we had a client recently too, this was like one of the wildest cases too. It was recently, he just left, but he was like convinced that there was something like wrong with his like stomach because he had a lot of like he said a quote like he couldn't go to the bathroom in like a month, which is like also not possible because he'd be like in the hospital. Yeah, he went to the hospitals at like previous places he went to, and everything was fine. Like medically, everything was fine.
Why does this sound like me? I've literally, my mom's like, you're such a hypochondriac. But I was talking about this on the last episode. I was convinced, maybe not to his level, definitely not, but I was convinced that I had a heart problem because I had such bad anxiety that I would have palpitations. And I was like, I have a heart problem. I need to go see a cardiologist, and everything was fine.
It's like, she needs ART.
I do.
Oh,
I found a therapist that does ART and EMDR, and
What does this look like? Is it one session and you're healed and you're fixed, or is it an ongoing? You said you work in a facility where most of your clients are 30-day, 45-day inpatient stayers, if you will. Is this something that is continuously worked on when they leave treatment as well?
So. Difficult question because sometimes no, it's not continuously worked on because it just depends like what their aftercare plan is. If they go to like another IOP that offers it, I would always recommend it. If they have an outside therapist that does it, I would always recommend it because again, like I said, EMDR is really thorough, and especially if someone has like a trauma timeline of like 20 things on there, realistically, that's going to take like a really long time to get through. ART's faster. Like I said, one session you could lower your distress level from like, let's say 0 means neutral or like not disturbed. 10 means very high level of disturbance. So let's say they're at like a 9 for like the car accident or whatever. In one session, it could go down to a 4, but it may take a little bit longer to go to a 0. And then an outside like factor, outside trigger could make it go back up, which is why I say like EMDR is just more thorough. ART is not as thorough, but it does, if someone's like freaking the fuck out, like it does make them be more like regulated, and it does give them some internal buy-in to want to stay and do the work as well. But it ranges too, and it's interesting too because even though we're PHP level of care, and like you said, the stay is 30 to 45 days. I've had some clients be with me for way longer because we are PHP, IOP, and OP level of care. So I have some clients, especially if they're local, like, and if their insurance allowance, but if they can stay, like, and I think they're like appropriate for, the EMDR, if they can handle it, they have like a baseline, we call it like a window of tolerance, like they're in, like they can do the work. Like if someone's like always dysregulated, you don't really want to do that with them, you know what I mean? Or they're not really into it, like also what's the point, you know what I mean? So it just depends. They kind of have to be in this threshold of like they're able to handle it. And then sometimes they step down. Like I've had some clients be with me, like I think my longest client was with me for like 10 months. Because he did like all the different levels of care and he was staying local. And at one point he was in like the OP level of care, which just means outpatient. And that's basically like an outside therapist. So he would only see me like once a week just for an individual session. He didn't really go to groups anymore. Like he was kind of all regulated back on his feet, but he still saw me because we had really good rapport and really good like, therapeutic relationship, and he trusted me. So he continued to stay with me and do like therapy and stuff like that. But I think it just depends on like, sometimes the situation of if people can stay longer or not. But I would always recommend them continuing to do it because the more thorough the better. But I think the goals I have, if I know someone's coming in, I know they're only going to be here for like 30 days, I try to at least do like, and if they're appropriate, like I said, I try to at least eliminate like one thing off their trauma timeline, or one thing that like I can at least level. I mean, it's better than nothing. You know what I mean?
Yeah.
In my ideal world, and one day I'll have my own private practice where I will be able to do these kinds of therapies, because I really am passionate about, you know, trauma work and helping that, and especially if there's something to really help and aid that. And I think it's good with talk therapy, because sometimes, like I said, you don't really talk too much during it. You kind of need to process out what the hell happened in your head, you know? So I kind of do both, or go back and forth.
Yeah. And for people listening, therapy is generally never a one-time thing.
I'm sorry. If someone said I went to therapy once and I'm cured, they're fucking wrong, because that's just not how it works. No.
Yeah. And also, I will say, it kind of seems like EMDR and ART may be good for people who, like myself, have been to therapy a lot, like years growing up.
Mm-hmm.
And like for myself, and although I haven't done it yet, I feel like I have talked about everything that I need to talk about. Like, yes, things come up during the, you know, every day, every week, whatever. And that I talk to you about a lot of this stuff. Yes, things still come up, but I feel like I've talked about like my traumas so much that I'm really ready to get into like deeper into my mind and like my physical body too. I feel like it kind of maybe seems like it's really good to maybe do, I wouldn't say after talk therapy, but if talk therapy is maybe not enough, would you say, you know?
Yeah, I always recommend that, because that's a lot of times people are like, I've done it before, and it's like, well, I've done treatment multiple times, like, doesn't work. And like, I get that, and I get the frustration, because it is frustrating, you know, and that's why I think a lot of people don't know about EMDR or ART or trauma therapy in general. Again, I think it's good in tangent, like you have to use it both. But I do think this will help like dive into, you know, what did you perceive about yourself through that experience, through that death, through that grief, through that loss of whatever else, you know, externally or internally that you felt. Like, what happened for you, and what did you then internalize from that? Because that affects a lot of your outside world a lot more than people realize.
Yeah.
Sometimes like little stuff, like little behaviors, like people might like clam up when people like are talking to them or touching them, or they feel like they're very disconnected, and that might be because, I don't know, trust issues or betraying, or things that they're not even conscious, or things they are conscious of. It just depends on the person, but
a lot of it's subconscious.
Yeah.
So with EMDR and ART, I have to keep looking at these acronyms. I'm like EMDR and ART.
My clients do that. They inverse it all the time, and I'm just like, go with it, sure. You can call it whatever you want.
Now, you can't compare these two apples to apples, but what is the highest rate for success with these two therapies? Give us examples of trauma you've seen come in that had the highest rate of success with these two therapies.
So I have two clients. One of them, he will be with me. Like I said, he had the benefit of having the continuity of care, so he kept going through the levels. Right now he's with me for OP, and he's with me bi-weekly OP, so he's almost done. He'll be, you know, discharged successfully at the end of this month, so I'm very proud of him. And then my other client, she's still with me weekly for outpatient, but they both are like what I consider more like a success story too, because he had a lot, and he has a lot of other trauma that we haven't even gone into all of it, but like he's just he came from a place where he was not being able to, like, he wouldn't even speak to me at first. Like, he wouldn't talk.
Wow.
Yeah, and we would have groups, because I run groups also. And we also have like a group we call caseload group, which I have 3 times a week, which is a little bit longer than, you remember that? You're like, oh yeah. And it's a group made of my clients. So like I'm like the one in charge of them all. And then I have other groups that I run. I run a lot of women's groups, a lot of codependency groups and stuff like that throughout the week on top of seeing my clients. But side note, but in this original caseload group, I remember it like very clear as day. He was like in the corner, like trying to hide himself. And when it was like we were going around and it was his turn to go, he would like give me like 1-word answers, and he'd be like, I can't speak or whatever. And I like gave him a little grace like in the beginning, because I'm not gonna like come at you. You have to build the rapport. Like when you build rapport, then I can kind of challenge you a lot more. I can't really like, especially you learn the person. Like every person's different, so I kind of am flexible depending on what they need. Like if I know like you're just gonna try to manipulate me, and I know you think you're gonna manipulate me, then I'll maybe come at you a little bit more. But like it just depends. But for him, he was like, he was, and I told him this too. I was like, you're like an onion. I was like, we'll go one.
There's
we'll
layers.
There's layers, and we'll go one layer at a time. And I think that was a corrective experience for him, because I don't really think that he's had like a positive, healthy, like person ever in his life. He also was a very strict, like horrible past trauma experience. He was in like sent away to like basically a cult for like 6 years, out of the country. No family really around that cared about him. He was one of 12 children. He just like had to fend for himself for so long. So his core belief is like that I'm not worth it. I'm not obvious. Like, you know what I mean? Not obviously, but like, how could someone not think that way about themselves? So a big one we targeted was a lot of his trauma, like in the cult in France of what he went through. And then since then, you know, it kind of derailed a lot of his, like, I don't know, like slowly, like a lot of his core beliefs about himself and his ability to function. And then over time, we've just like, he trusted me. He came to me with a lot of stuff. He started opening up. He started making jokes and laughing. And like, you just could see him like kind of come back alive again. And it was very, those are the moments. Yeah. Like those are the moments I have to remember when people are pissing me off.
Yeah.
Or I'm like, oh my God, this is just like, you had really bad days or things like that. Like those are the moments that I hold on to. Because now, like I said, he's in biweekly level of care, and we still do the EMDR sometimes. Like I said, not everything is cleared off his list, because he had a multitude. Like his list would take him like years to go through, if I'm honest. Like he had so much stuff on there, but like crossing out something big, or at least lowering it for him from like a level 10 to like a level 4, something around there, like significantly it changed his person. Like he even says to me, like, I feel like I don't deserve everything bad in my life. And like just hearing those things, especially coming from where he came from, where he wouldn't talk to me, and now he's dying to talk to me every you know, other week. It's very nice. And it's not about me, or it's not about the therapist. A lot of times it's really about like, and I told him that too. I was like, you did this. Like you did it. Like you were able to trust somebody else and let me, and I take that as a privilege to be able to have these people open up to me, because they don't have to do that. They really don't. And I think a lot of times people want to do the work, but they don't feel like either they deserve it, and the people that do actually come to treatment sometimes aren't always the people that necessarily need to. Like, not that they don't need to come to treatment, but like a lot of times people that do need help won't get the help. Like,
and a lot of people.
Yes. And a lot of like their families. And I have to call the families like their appointed person like once a week also. And some of these families, I'm like,
y'all need to be in here too.
I'm like, you need to be here as well.
Yeah,
and I'll be like, so have you considered your own help? And they're like, no. I'm like, we shall.
You talked about the boxes before and safe spaces.
Yeah.
In the beginning, obviously there needs to be some kind of good rapport and trust built with you before someone can start that journey. Do you find, let's kind of flip it around. Well, people are shelled up in the beginning. You create that safe space. Have you seen cases where, and I've just from going to meetings, people are very open to just blurting out their trauma with someone they just met. What are some of the ramifications, and is it detrimental to maybe surpass that comfortable stage in the beginning and setting a safe space?
Yeah, good question. Because I think a lot of times people handle their trauma in different ways. And sometimes people either do that way where they like shut down, or they don't really share anything to other people. Or sometimes they really do the opposite, where they like trauma vomit on you, and they'll say it to like every Joe Schmo at the grocery store. And I think it's about realizing like too of like, you know, when I have them come into, and if it's like one of those, I'm like, this is your space. This is your time to do it here. It's appropriate here. But it may not be appropriate too in like every group. And we do that also of like that we have trauma specific groups, and then we'll have other groups that like is not about that. And sometimes it's counterintuitive. Like you don't want them just sharing all their trauma. Like not that we don't want to hear it or, you know, have that, but like in the right spaces. And we always go over that in the beginning too. And I think it's about specifically with those kinds of word vomiter people, giving them a little more psychoeducation and some boundaries regarding it, you know, and being like, hey, like I want to hear from you, but also like this is the space to do it. Let's do it. Let's keep it here. You know what I mean? Or let's keep it in these couple places instead of being like all over the place, because then it's sometimes like, and with some people, like they do that. Not necessarily always on purpose, but like sometimes they really just they want to. I don't want to say scare other people, but they
want to see how they react.
They want to see how other people react.
I've been there.
So sometimes it's a manipulative thing. Sometimes, not always, but I have seen it with like a lot of my BPD clients with borderline personality disorders. A lot of times they spew their trauma, and it's not necessarily that they don't, believe in it or that's their own reality. And I totally agree with that. But sometimes it's like sometimes counterintuitive just to word vomit because they're just wanting to listen to themselves talk, or they're like, it's not really helpful sometimes at some point, just like getting it out there. Like you have to, what are we doing with it? You know what I mean? Like, where are we putting this that you just shared? Like, I'm glad you shared it, but like, why are we sharing it in every group every minute of the day? Like, then it's like, something else is going on. And sometimes that's like not necessarily like just about the trauma. It's about something else going on.
Need for attention, potentially.
Yeah.
Is the manipulation them wanting to kind of almost steal the show? And
sometimes
it is directly correlated with a deep-rooted insecurity.
Yes.
And them wanting to be about themselves.
Yeah, and I think sometimes people have like this narrative about like attention, that it's always like a bad thing. Like people need love and belonging. People need attention. But I think sometimes with those kinds of clients, like with personality disorders in general, it's an environmental and a trauma-based disorder. It's not usually genetic. Genetic are more like mood disorders and those kinds of things. So when those develop in early adolescence, you see them more in like your adulthood, but they'll always have been there before. You don't diagnose it until later, hopefully, if you're a good clinician, but you don't diagnose it until later. But when you see those, you kind of realize like, wait, like there's actually something else kind of going on here, because it's not just about like what they're really talking about. It's about maybe they felt that abandonment wound and that's why they feel the need to have that attention on them. What's going on a little bit deeper for them?
I can vouch for that. Weirdly enough, like I think there were times throughout my life where I, as a adolescent, maybe not necessarily a child or young adult even, where I kind of wanted attention for whatever, anything.
Yeah.
And I think as I get older, I kind of realize like I got a lot of special attention from my dad, and I lost my dad when I was 7 years old. So I think that that I all of a sudden didn't have that attention anymore. And like, obviously my mom did her best, but it just was such a drastic change in my life that I think that I then kind of tried to make up for that attention in other ways,
Yeah. And that's the thing. And I like that you said that too, because it's not like attention doesn't always have to be a bad thing. Like I think just sometimes it's used with behaviors that aren't so like maybe more maladaptive, or there's other intentions behind it. But sometimes people need attention. It's usually coming from something that they're lacking. Yeah. And a lot of that like behavioral issues or with personality disorders often stem from deep-rooted trauma and environmental issues that went around them. And that's why the personality disorder developed, because it's like almost a survival skill.
Yeah.
It's funny, too much of that attention. So when that is a symptom of mine, so the meetings that I go to, those are symptoms. And yes, everyone needs love. Everyone needs attention. Yeah. It's important. But too much, and when you're manipulating a situation, and that is the same thing as me gambling. That is the same thing as sex addiction, whatever, overeating, whatever it may be. I am never fulfilled. I am just trying to fill the void and fill the void and fill the void until I actually get to the root of. So that's interesting that someone would overshare their trauma in a space that isn't safe to manipulate, and it's really just another symptom of what happened from that trauma. That's interesting.
Yeah, I see it all the time. It's like, especially, it's like, it doesn't always have to be a personality disorder. Sometimes it's just the way that people have learned. Like, if I say something like outlandish, people will be like, oh my God, like, and notice me. And like, they're probably not, and maybe they never got that. So that's their twisted way of getting that. So it's not always like in a bad way, because I don't really like saying like bad way, because I feel like people might internalize and have shame about that too. But it just is like looking at the behaviors and sometimes separating ourselves from behaviors, but what's not working for me anymore and why, and what's my secondary gain. There's a lot of that in that, which ties to EMDR also, because we have to look at somebody's like secondary gain of something. Sometimes people won't want to resolve their trauma because they have a secondary gain from it, and that we have to take into consideration when doing EMDR. So if someone really wants that, holds on to their trauma as like their badge of armor and they don't really want to let it go, they may not let it go, and they might like never get down to like a 0. They might just keep it at a 3, and because they know that you're going to keep being there and keep trying, you know what I mean? So it's like kind of that like, sometimes like clients will play it out with me to like mimic their own shit with their family or whatever else. I've seen that a lot of times.
That's helpful though. No?
Sometimes and sometimes not. If it's in a recorrective way and like I'm like more like and they're like learning and they're not like using it to their own advantage, yes. But sometimes when they're just like, I'm not gonna like let this trauma go. I'm gonna keep coming up with stuff.
Oh, got it.
Like just to have you be there because I know you're gonna still be there. It's like almost playing into their game, even though I can't really do much about it,
Okay, so I have a question about trauma responses. I think that would be the correct term. So some people remember, say, the most traumatic day of their life, and some people don't remember it at all. And just to give people a little bit more context and to give a real life example, the day that my dad died when I was 7, I remember that day like the back of my hand. I have, to just go to the opposite end, a family member who sadly lost her husband, I think a little over a year ago. She was there when he passed, and she doesn't remember like a solid 12 hours maybe at all. Mm-hmm. She does not remember at all.
Yeah.
And I don't think she wants to remember. Mm-hmm. So she's probably, I don't
another
really
secondary
think,
gain.
Yeah. Can you just maybe explain why some people have the total opposite end experiences of that?
Yeah, I mean, I think the simplest way to do it too is like it's a survival skill. Like your brain will block things out of your memory. It's sometimes why like you can be like passing something on the street and you'd be like, oh my God, and then like unlock some kind of random memory for you. Like it's stored somewhere, but it may not be stored in like the certain like
your conscious
mind. Conscious mind, or maybe more like your initial like short-term memory. It might be stored more in long-term memory, so it can be still uncovered with like other stuff. Like, and if they don't want to target that, like you can target something else, but sometimes it might lead to that anyway, which is good. But I think people block it out, because they don't want to remember it.
Yeah.
So a lot of times with that, like you tap more into the body, like because it's held somewhere, so. If they can't do that, like, right, but she didn't remember that 12 hours, right? She remembered some part of the evening, some part of something, right?
Yeah.
Of like the death. So you can go with that. Like, it doesn't have to be like, remember, you know what I mean? Because that's not going to work. And she may really not remember it. Her brain is trying to protect her. So it literally blocked it out from her. Like, it literally physically blocked it out. And that's very real. And sometimes it will come back and sometimes it won't. But
she said she doesn't want to remember.
But then that's also ties into like secondary gains of stuff.
Yeah.
Like if she really doesn't want to remember something, she won't remember it.
Yeah.
What does effective trauma therapy look like? You mentioned you had a client, I think, who's with you for 10 months now.
Yeah.
And they dialed back on the number of times they come in. What does a successful case look like for you?
I think when they can like regulate themselves, especially, I think it also determines, it is case by case, at least for me, because you have to see what they came in like and what their baseline is and what is their abilities to function in the outside world, because everyone's going to be different with that. Like for a client that like hasn't left his house in like a year, not him, but like just for example, like if a client hasn't left their house in like a year, expecting them to go, become president of a CEO company is like not really in the cards. So like, not to say it's not, but like that's not, wouldn't be considered like a success. It would be more like ADLs. So ADL stands for activities of daily living, aka like cleaning, cooking, making doctor's appointments, like, brushing your teeth, like things like getting dressed, like those kinds of things. Like I have a lot of clients that like I have to do like ADL checklists with that are very like low functioning of like they don't really have that. So for a client like that, like who came in and like wasn't showering, like a successful would be like they wake up in the morning, they're on a routine, like maybe they get like a part-time job, like that'd be a success for me. So I really think it just depends on like the person and what their presenting problems are and what their baseline is, especially once they come like off drugs or alcohol or whatever their issues, or if it's just mental health, what is their baseline of depression? Is it 1 to 10, like what does it look like without anything else going on? What is their level of overall functioning without any substances in them? What does that look like? So then I can base my treatment plan off of that, and I can see like how they look like in the daily functioning, at least at a treatment center level. And then that's also what I do for like step down care. Usually it's not in my control. Unfortunately, it's like a lot more insurance. But with certain levels, like maybe like when they get OP, I can kind of like the outpatient, I can kind of determine when I go from weekly to biweekly to step them down there. That's usually where I have a little bit more control over, because insurance doesn't really care about that part.
How much does something like this cost out of pocket?
I have no idea.
Oh, they keep the numbers from you. Okay, smart.
Yeah,
A shit ton. We know that much.
I'm sure they're making a lot of money off me.
Do you think it's a problem in the U.S.? Is it easily accessible for someone who does not have insurance? Do you need insurance?
Some places I think will cover it. I think with like a whatchamacallit, like a outpatient client, like a outside therapist. That's what I meant to say. Like sometimes, like, you know, Allie said she found one that does it. Like sometimes insurance will cover, like they'll take insurance and it will cover all the services that she offers. Sometimes it won't. So it really just depends. I do think there are a decent amount that offer it, but it is very niche. So it's not like the majority of therapists you have won't have that necessarily. Like you have to find it. You have to really like look for it, you know, because it's a whole training. For EMDR, it was 5 full days, morning and night. I think it was from like 8 a.m., 8 or 9 a.m., I can't remember, to like 4 or 5, maybe 6 p.m. And you got like a break for lunch a little bit, but like it was that for that 5 days in a row. And then for ART was 3 full days.
Wow. Rigorous.
Yeah, so you're there. It's like, it's not so long, but it definitely is. And then for EMDR, you had to do supervision for 3 months after. Basically talking about starting to do it with your clients, seeing what works, what doesn't work, like questions you have, things like that. So there's follow-up with that too. And there's also additional trainings if you want as well. But it's also finding courses, you know, finding it is more difficult, and finding people that do it. Like I do think there's a decent amount of people that do, you know, have this, you know, approach or this technique, but I don't think it's as common as like, you know, just being a therapist, you know, or having your, you know, master's
definitely
or
not
license.
as common. Like I didn't even really know what it was until you told me. I had heard about ART, but I didn't know what EMDR is, and I had to, like, just to give people some context, if you're looking, you know, to find this type of stuff, I found it through a reference through my psychiatrist who prescribes my antidepressants. But I like online. I know there's certain sites where you can find. Do you have any recommendations for people?
I mean, I will say, in like, I know we're in Delray, like this is a huge like recovery hub.
Yeah.
Like you can't throw a rock and not find like something around here.
Yeah.
The hub is a big resource for just like a lot of people who don't have a lot of money or references. So they do like a lot of, not pro bono is not the right word, but they like do help with like no money. Scholarship, I guess. I don't know.
Yeah.
But usually, and we have a case management department that finds a lot of like referrals and IOP programs and stuff for them. But yeah, I honestly like Google helps. Like I know I don't have like a lot of
you can
lists.
find everything online though.
But I wish I had more like off the top of my head, but usually I don't find them referrals like of specific people, but there is a lot in this area, and like you can literally look on like any kind of like, could be like therapist aid, or like that's a lot of where it has like mental health resources and stuff, and like you can literally type in, like I've literally typed it in myself, like therapist near me, and like what you're looking for, like if you want like more like reframing, like cognitive reframing, taking negative beliefs, turning into more positive like beliefs about self. That's called CBT, cognitive behavioral therapy. There's DBT, which works really well with personality disorders, dialectic behavioral therapy, which is kind of like CBT, but then you take like an emotional dysregulation part in that. And then there's, like I said, there's EMDR, there's ART that's more trauma based if you want to like kind of focus on that. If you want to do more like psychoeducation, you don't really know about therapy or things like that. And a lot of therapists give you like different perspectives, and they all have different approaches. So like I do a lot of more like reality based therapy. So like I don't think that one person's wrong, one person's right. That's your perception, your reality of situations. But there also could be another reality or perception out there as well. Like they don't have to like negate each other, but they can both exist at the same time. So that's a little bit of like my approach. Is I do a lot of different stuff, but there is a lot of different varieties of what people do. They're psychoanalytical, where they're very, analytical about and dissect. There's inner childhood techniques where they talk more about, your past childhood, and they kind of connect it to how your core belief system and your behaviors are about now. There's Gestalt, which is a lot of like, we call it like empty chair work, which is like a lot of grief work, and a lot of, and also another trauma approach too, which like use like an empty chair. You can mimic like family sculpting. I do a lot of that. So family sculpting is like where you mimic your family dynamic, and you basically have to like talk to each person you bring in, like, and it's like you can have people in the room like represent them. Like I could be like, Kevin represents, my, sister. Well, not
what. I know my hair looks good, but not that good. Come on.
Yes, it's Babu. No, but you can have anyone represent other people, or you can have it empty and have an empty chair. But then they will talk to them, and then we'll guide them through of like, what do you need to say to that person? What do they represent? Why are you bringing them up here? And we kind of like push and like kind of ask them what they need from that. That's called family sculpting. There's a lot of different approaches like therapy wise. So if you're really looking for something, it just depends what you're looking for. You know what I mean? Like, and if you don't know, you pick somebody and it's process of elimination. You know what I mean? Like you're not tied or tethered to anybody.
Yeah.
And sometimes it's not like anyone's fault. Like maybe they're just, it doesn't work out, and it doesn't have to be internalized like, oh, I'm a bad client or a bad therapist. Like it just does, it's not a match, something like picking a partner. Like we're just not it, and that's okay.
They say finding a therapist is like dating.
It is.
And it's exhausting sometimes, but both things.
Yes.
So Rachel, what advice would you have for the person who is listening, or just sitting at home and contemplating that, they'd like to look for trauma therapy, or enter a facility? What advice, and they haven't done that yet, what advice would you have for them?
So there's an analogy I heard once. I want to say it was like maybe 5 months ago, and I really, really like that. So it kind of goes into your question. So, well, one, I'd say do it. Obviously, I know I'm biased, but
just do it.
Just do it.
That's the most. No, it is. That's
great.
Yes.
Said it best.
But the analogy is that if you imagine like a cup, right, or like a bowl, and the different traumas in your life are ping pong balls, and then the water you put into the bowl is healing, right? When you put the water into the bowl, the ping pong balls, the trauma is going to start rising to the surface. AKA when you start to heal, people think, oh, I'm doing great, I'm regulating all this. Oh, now this is coming up for me with this. Like, what's wrong with me? I'm like, no, this is when like the push comes to shove, like you were saying earlier, of like, oh, I finally got a little by and now I'm scared, I'm going to push away. That's kind of what happens. And most people will start to quit when that happens, So it's like, let the ping pong balls come up, let the stuff come up, because eventually the more water you pour in and continue to pour in, even though it's tough, even though it's hard, the ping pong balls will overflow, and then they won't be there anymore, and it'll just be water. So keep going, keep like persevering, and don't let the fear of what you think could or couldn't happen prevent you for what really could be.
You're not the first one to do it. You're not going to be the last one doing it. So just go ahead and do it, because you're in very good company.
Yes.
Yeah. Well, thank you for coming on, Rachel.
Thank you
and
for
Allie,
having me.
thank you so much for joining
Of course.
as well.
I'm here for support mainly, but you did amazing.
Oh, thank you.
Thank you, ladies.
Thanks for having me.